title of this lecture is precisely the title of my new book, Hidden Epidemic, with strong emphasis on the subtitle, which is Silent Oral Infections, meaning infections that are completely asymptomatic and you have no idea they're there. Silent oral infections cause most heart attacks on the order of greater than 90%, and most breast cancers on the order of greater than 70%. So when you consider the impact of heart disease and breast cancer alone, those two things together kill vastly more people than any other thing on the planet. Now, briefly, I'm going to recap some of the things I talked about in the first presentation as we come into focus more on the dental infection and dental toxicity connection to really all disease. So, once again, to reiterate, all promoters of chronic degenerative diseases share the denominator of being caused by increased oxidative stress, which is loss of electrons and inactive biomolecules because they're oxidized. With this in mind, then, the things that directly promote such chronic degenerative diseases are, number one, infection-related toxins. Number two, toxins that are unrelated to infections. Number three, the other side of the coin, insufficient antioxidant or nutrient counterbalance to supply electrons. And some of you might wonder, well, where does genetic disease fall in the line? Well, obviously, some people have genetic diseases. Is that an exception to this concept of increased oxidative stress? Well, absolutely not. A genetic disease, for the most part, is typified by decreased activity or absence of an enzyme. And what will that do? Well, that will just make a certain area of tissue more susceptible to increased oxidative stress. So it still falls into the same picture. And finally, hormonal deficiencies and imbalances. So what do all toxins and infections have in common? They all, both of them, infections and toxins, cause cell and tissue damage by increasing oxidative stress. Now, it's also important to keep in mind that biochemically, the components and biomolecules in the body and the things that you ingest almost simplistically come down to their either antioxidant or their pro-oxidant. On rare occasion, you might have something that's completely inert, and if it's an inert, there's no electron transfer at all. So when the biomolecules have their full contingent of electrons, they're optimally active and optimally doing the job that they were designed to do. When they're oxidized, they may either be partially inactivated or completely inactivated. It just depends on the biomolecule. And so collectively, the larger the percentage of biomolecules in a given tissue or area of the body, the larger percentage of them that are present, the more disease, the more manifest the disease is. The more you can chip away at that and lower the ratio, the more you can improve tissue and physiological function. Also, this translates into electricity. We haven't talked about it a lot and haven't really talked about it at all today. But when you have a brisk presence or a large presence of vitamin C and other antioxidants at the cellular level that are present to relay electrons from one biomolecule to the next, you actually can generate microcurrents. okay? A microcurrent is electron flow. A current is electron flow. So the more effectively you can stimulate redox, reduction oxidation activity by all the mechanisms we've talked about, the more you assure that the bodies and the tissues and the cells have their natural, normal, optimally effective currents. And the corollary of that is electrical differences that also helps ensure that you have healthy transmembrane voltages, okay? This has been well documented, again, although it's not discussed much. When you get your transmembrane voltage at like minus 70 or more, you have largely a healthy cell, or it's reflective of a healthy cell. And when those voltages lessen, these are also manifestations by which cells become diseased. This also plays a role into why magnetic fields, pulsed electromagnetic fields and static electromagnetic fields can have such positive impact on pathology. I mean, when you're in pulsed electromagnetic fields, you're having a magnetic field going in like that. Well, as a magnetic field moves, you generate an electron flow at a right degree angle to that. So it's all interrelated. So we saw this slide this morning, and I'm not going to dwell on it, but just reiterate the treatment principles for all diseases are to prevent new toxicity, neutralize existing toxicity, excrete existing toxicity, resolve infections that continue to contribute to toxins, supplement and eat optimally, and address hormone imbalance. Okay, now on to the single biggest contributor / cause of the toxicity that causes all disease: oral infection and toxicity. Number one, nothing else comes close. Yet, so far, it's still being largely ignored, and there's a lot of needless pathology and suffering and death that's occurring because although it's changing slowly. This needs to be recognized and addressed promptly, and I'm going to give some practical suggestions that I would hope you'll be able to apply into your practices right away, because physicians need to work with dentists and dentists need to work with physicians. It seems silly to say that, but it's the same body, okay? And nothing is more intimately involved with your health than if you have an infection in your head and what's going on in the rest of your body. It's not, these things don't exist in isolation, not even close. Okay, so number one is the root canal treated tooth. The root canal treated tooth is always infected. Not necessarily clinically impactful, and we'll talk about that. That's something that has changed. We've tried to keep up with the literature as they do it, and for a long time it appeared that all root canal treated teeth were horribly toxic and going to kill you, and that's not quite so clear now. So there are subsets where one is an extraordinarily high negative to your general health, and there's another scenario in which it could be of no clinical consequence to your health. And I'm going to discuss how we should construct studies in the future, because we don't have the data right now to tell you for sure which are bad, which are good, which are so-so. I'll give you my suggestions and my personal impressions, but it's not based on a study yet to date. So you have root canal treated teeth, and then you have the entity that the new book in this whole topic is based on, and that's other chronically infected teeth that have not received a root canal. but they're infected. And they're infected asymptomatically, and you have no idea at all that you have a horribly infected tooth in your head, giving you your heart disease, giving you your cancer, giving you your lupus, giving you your fibromyalgia, your Alzheimer's, your Parkinson's, unless you specifically look for it with the right technology. Both are important. You need to use the right technology or you'll miss it. And in missing it, you will miss the one chance that you have to, if not cure that patient, give them a much less symptomatic and longer life. And this is known as chronic apical periodontitis, which basically means a large radiolucent area at the tip of the roots of the teeth, and I'll refer to this as CAP, C-A-P, okay? The number 3 is a symptomatically infected tooth. That's pretty clear cut. If you have an acutely swollen, infected, painful abscess tooth, it's got to come out so quick, because something like that will take you down and kill you in short order. Then you have the chronic gum disease, which is interrelated to this because this usually supplies the pathogens that end up infecting the tooth. So the pathogen profiles of infected gums is the same as the pathogen profile of the typical pathogens infecting the inside of the tooth. And we've already had established now for decades a direct association and often cause and effect between chronically infected gums and virtually every disease. Virtually every disease they've bothered to look at, all right? If it doesn't exist, it's only because they haven't specifically looked at it yet. But the reason why this is such a broad swath that affects so many different things is severe chronically infected gums inflict not just a localized inflammation, but a body-wide inflammation, almost always associated with increased levels of C-reactive protein. And this is not just a marker, but it's also a cause of disease. CRP, for example, will not only tell you that you're in danger of getting a heart attack, it's also a primary player in giving you that heart attack. Now we have cavitations. Probably not going to talk too much about that, but know that it's a common oral infection. When it's very large and extensive, it can be massively impactful on your health, but most of the time when it's smaller, at an old extraction site, you have a little infected hole, and it's filled with nasty stuff. It's filled with wet gangrene. But anything, no matter how toxic it is, if it stays relatively contained, you can avoid body-wide systemic impact on your health. It all has to do with how well it is contained. Chronically infected tonsils, I talked about that briefly. I'll give you a little more information on that. Infected dental implants. Dental implants are great, but if they get infected and you don't either extract them or find a way to resolve the infection, that's going to bring your health down too. I'm not advocating against implants. I'm just saying they need to be monitored over time, just like everything else, to make sure that what was once a good dental solution for you hasn't now turned against you. And there's lots of things you can do. It doesn't have to ambush you. I mean, doing certain x-ray studies, doing certain dental examinations, you wouldn't need to see your dentist more than every 6 months just to do a quick check. And finally, actually, interestingly enough, because there's been so much stuff going on in the literature for the past 30 or 40 years on mercury amalgams and these toxins, I can tell you that absolutely you don't want mercury in your body, not one more molecule than you need to have. But I'll also tell you that the toxicity of mercury doesn't doesn't hold a candle to the toxicity of these infections. So when you're dealing with, well, I tell dentists that if somebody comes in with very limited funds, and that's a very realistic thing that we all have to deal with our patients, and they have 10 mercury amalgams and 1 root canal with a big CAP lesion on it, what should they spend their money on? Getting the mercury out or getting the root canal out? And the answer isn't even a close call. It's get the root canal out. Okay, that'll bring you down quick. I mean, the mercury is supplying toxicity, but it's not seeding pathogens that are being distributed throughout your body and setting up shop inside your coronary arteries. So, that was the list of different dental toxicity infections. Now, what's the prioritization? What is the worst working on down? Most disease is impacted negatively by root canal treated teeth, although there's going to be a subset that doesn't impact it, and I'll tell you about that. The asymptomatic infected teeth, the cap teeth, are probably the most toxic entity there is. Okay, they're substantially more toxic, and they actually have comparative studies to show this. They're substantially more toxic than just about any root canal treated tooth. And that ends up being one of the rationalizations for doing a root canal, if those are the only options left, is it will decrease, at least in the short term, versus getting extracted. At least in the short term, a well-done root canal will debulk the infection at the root tips of a CAP tooth and make it substantially less toxic. And if the root canal is done extremely well technically, and the inside of the tooth is well sealed off, and there's no continuing accumulation of toxins at the root tips, it can be something that can serve you well. Chronic gum disease and chronically infected tonsils. Now, just in case it sounds like I'm just making wild generalizations when I say all root canal treated teeth are infected, I assure you I'm not. When Dr. Huggins, about 20 years ago, had a interaction with Dr. Boyd Haley of the University of Kentucky, an absolutely brilliant researcher that deserves the Nobel Prize, not that that would ever happen. But he's a professor of chemistry at the University of Kentucky, and Dr. Huggins said, well, we're extracting these root canal treated teeth. We'd like you to examine them for toxins. And Dr. Haley devised a test that looked at 5 different critical enzymes in the human body that all relate to energy production. And Dr. Huggins and a network of dentists around the country sent these extracted root canals into Dr. Haley for his analysis. Now, they finally stopped counting after 5,000 were done. And the 5,000 extracted root canal treated teeth, 100% of them had incredibly potent toxins that were able to just completely decimate these enzymes. And just to rule out the possibility that any sort of contamination was involved, they also examined a bunch of teeth that were just normal teeth but extracted for routine orthodontic reasons. In other words, making room for braces, allowing a child's mouth to grow out. And none of these normal teeth that were extracted had any of these toxins. So if there exists a root canal treated tooth that's not toxic, it's vastly less than 1 out of 5,000, 1 out of 10,000, 1 out of 20,000. Logically, it's 100% because of the nature of the procedure. The nature of the procedure is you either present to the dentist with this CAP on a tooth or a very painful tooth. And so the goal that the endodontist or dentist establishes is, I want this patient to walk out of the office with a pain-free tooth. Not concerned at all about infection or pathology, just eliminate the pain. Well, all of the nerves and connective tissue and blood vessels, lymphatics, everything else in a tooth are in the middle of it, it's in the pulp. That's the life force of the tooth. So the procedure, the root canal, goes in and routes out that pulp, just gouges it out as completely as possible. Well, what do you do when you take out the pulp? You take out all the nerves. So how are you going to feel pain once you take the nerves out? You don't. And that's what happens when you have a quote-unquote successful root canal procedure, is you've literally cut away all the nerves that transmit pain. Now, it's possible in a quote unsuccessful root canal that you still have pain. Well, that pain is due to there's something going on at the apex of the tooth. The pain's not coming from the core of the tooth because you've taken the nerves out. So, this then is what I call, at least in terms of infection, a fatally flawed procedure. There's no way that it could be done in which you're going to end up with a tooth that's not going to be chronically infected. Because even if theoretically you started with a tooth that wasn't infected, which virtually never happens, but let's say you do, you start with a tooth that wasn't infected, and you core out the nerve and blood supply inside the tooth. When you do that, a bunch of things happens. One of the things that happens is there's a natural fluid flow in the tooth. And when it's a healthy tooth, the fluid flow goes from the inside out. It's kind of like a continual flushing mechanism. When you take out the core of the tooth, the nerve and the pulp, that fluid flow reverses. And it brings all the garbage from the mouth inside the tooth. So even if you weren't infected when you had the procedure done, within a few days you'd have a fully blown infected tooth. And even more importantly, to assure that that tooth is infected, you have lost the access that the immune system has to the infection. You have dentinotubules, and these little pathogens line up single file, and in these tubules, there are miles of tubules in one tooth, miles. A lymphocyte or a monocyte or a T cell or a B cell or any component of the immune system doesn't get where it needs to go by magic. It gets where it needs to go by access, okay? A monocyte is not going to jump across an evacuated pulp and get into the dentinotubules any more than you're going to jump across the Grand Canyon, okay? So it needs access. And when you take away not only the pulp itself, but all the connective tissue, that's how immune cells get somewhere, is they migrate on the connective tissue matrix. Well, that's been taken away. Now, in studies that have looked at the pathogen flora of root canal treated teeth, they've identified over 460 different fungi and viruses and bacteria and protozoa. This is another reason, too, why some root canals are much nastier than others, is because you really don't know ahead of time what the unique pathogenic flora is going to be inside that tooth. And one thing that appears over and over and over again in the literature is that the toxicity of one pathogen plus another pathogen plus another pathogen is not three pathogens. It's synergistic. So the more pathogens you get, the much higher pathogenic outcome results. Now, they've also analyzed root canals for endotoxins. And this is kind of impressive because every study that I was able to find showed that 100% of the root canals examined had endotoxins. You can see the figures there. One is 30 out of 30, another's 21 out of 21, and another's 34 out of 34. So it's kind of hard to get more 100% than that. So I said much of this, fatally flawed procedure, immune system doesn't have access, the fluid flow reverses, and you have a brand new anaerobic environment for your pathogen. Now, first understand that a tooth, if it's in the normal state, it's sterile. There's no low-grade infection of any kind that exists in a normal tooth. It should be sterile. Well, the other thing that happens is the pathogens in your mouth, like different forms of Clostridium. What happens when you get Clostridium botulinum trapped inside a vacuum-packed can? Well, you take away the oxygen and you start producing botulinum toxin from something that would otherwise be innocuous, okay? It wouldn't cause any problems at all if you didn't put it in this anaerobic environment. But anyway, we're tinkling there, okay. When you put these pathogens in an oxygen-deprived environment, they do the same thing as the botulinum inside the vacuum-packed can. They produce toxins that are, believe it or not, when Dr. Haley first checked these toxins, up to 1,000-fold more toxic than botulism. So the degree of toxicity is just mind-numbing. Now, I mentioned this earlier, but I'll re-emphasize it right now. Well, right now is the delivery system of the toxins, okay? It's almost diabolical because you just couldn't design a situation that could be more harmful to the body than to not only have something that can generate these pathogens and toxins 24/7, as they say, it's also sitting in a perfect delivery system to be disseminated throughout your body every time you bite down on something. I mean, the pressures that are generated between two molars when you chew are mind-numbingly high. And they just get squeezed directly into the body. Nothing is wasted. Not only do they go to the coronary arteries, they go to the cerebral arteries too. And we have some studies to show how well they correlate to cerebrovascular accidents. In the case of the breasts, it's not so much the venous flow as the lymphatics. I have a slide that shows the lymphatic drainage, and you can see just at a glance how the lymphatics draining the jaw are shared lymphatics with the breasts. And when you do thermography on some of these women anyway, you'll actually see red streaks going straight down from the teeth on into the breasts. Fully 70%, a minimum of 70% of breast cancer is caused by infected teeth and gums, period. And if you have anyone with breast cancer and you haven't had their mouth evaluated, you're doing them a horrible misservice. And you're giving away their one chance at a true cure. I mean, you could have lots of effective therapies, like we said, that can help resolve the cancer, but if you don't resolve what caused the cancer, you're really doomed to long-term failure. You're doomed to either recurrence of the cancer or some brand new cancer down the road. Now, so, a number of the factors then that determine how a root canal or infected tooth is uniquely bad or not so bad has to do with the following factors. I mentioned the flora, okay? Obviously, you could have a wide variety of different pathogens. Number two, the tooth involved, okay? Again, I'm reluctant on the basis of the data that we have today to ever recommend to somebody that they have a root canal, but it doesn't mean that I feel that for sure they're doomed if they do. But even if you don't recommend it, it doesn't mean that it might not occasionally serve someone well. Think about if you have a root canal and an incisor at the front. You got one canal, you fill that up quite tightly, there's no residual CAP, and you don't chew with an incisor. You might do one nip to take the bite out, but all the chewing is with the molars. So you're not remotely, mechanically traumatizing and distributing the pathogens that are toxins that are inside that incisor versus an incisor molar. Also, containment. The root canal treated tooth almost always has some degree of cavitation of the bone associated with it. Sometimes it's advanced, sometimes it's minimal. But basically the infection at the tip of the tooth starts eroding away and eating at the bone inside the jawbone. This can be so extensive that in patients who are edentulous, they no longer have teeth, and they had their teeth extracted in the traditional fashion, which is not to properly clean out the ligament and everything else, but just to pull the teeth out. When these people get re-examined, they have such huge defects in the bone that you could place a small pencil in it. And here's the other kicker. In patients like this is one of the worst forms of dental toxicity because they now have clear-cut studies that show the less teeth you have, the sooner you die. Now think about this. You have the toxicity of the cavitations that is so overwhelming that even if you had extracted a bunch of infected teeth to get to the edentulous state, you still have a situation that's more toxic and more damaging to your long-term health. So it's fine to be edentulous, but the extractions have to be done correctly if you're going to get proper healing and not this residual cavitation toxicity. Okay. Now, on to the primary point / discovery / awareness of this whole book coming out is about 1.5 years ago, I was with a friend at the dentist, and she was getting a bunch of her root canals taken out. And in the course of doing those extractions, the dentists were quite appropriately mapping out the anatomy, seeing everything that needed to be seen, seeing if there's any other undetected pathology. And so she had 3 root canals in a row on the left side and then one other tooth that had been untreated, that had never received a root canal. And they did the 3D X-ray, the 3D cone beam imaging. Very special technology, but not that uncommon, but very special technology. And when they threw the X-ray up there, I looked at it and I was stunned. I was stunned because she had had chronic sinus problems for all her life, and so you could see on the 3D there was a clear fluid level in the sinuses, and then right below it was this tooth with 2 of the hugest defects I've ever seen, one of them completely eroding away the floor of the sinus and going into the sinus, eroded away the bone. And I said, "Has that tooth ever hurt you?" I said, "No." I said, "You can chew just like you want? You never have pain?" "No, it feels fine. It feels fine." And I saw at a glance that this had to be the most toxic thing on the planet. and it was asymptomatic. It's like having a time bomb in your mouth, time bomb in your body. This is not a subtly infected tooth. This was a grossly infected tooth. It looked like an acutely abscessed tooth. And X-ray-wise, it was identical to acutely abscessed tooth, except it was not acutely symptomatic. Thus the title, Silent Oral Infections. Okay? So after I started doing some research on this, I called her up and I said, you know, you're patient 0 of the biggest epidemic I think I've ever seen. Because this epidemic affects conservatively 70% and more like 90% of all the adults on this planet, and is the primary feeding mechanism for every chronic degenerative disease there is. I just used the title of the book to focus on heart attacks and breast cancer because those are the two we have the most definitive proof for. And because you don't want to go on with a subtitle that's 2 miles long or you lose the point. I mean, the point of a good title is you want to grab somebody's attention, give them the essence of the book in a few words, and proceed from there. Well, the essence of this book is a silent, undetected oral infection causes most heart attacks and breast cancer, and even if it didn't do anything else, which of course it does, but even if it didn't do anything else, that would be an overwhelming epidemic all by itself. 90% plus of heart disease, 70% plus of all breast cancer. So what is apical periodontitis in physiological terms? It's a group of inflammatory diseases caused by microorganisms, usually bacteria, infecting the necrotic. Necrotic means dead. So anytime you see apical periodontitis, the tooth is dead. Now, this causes a little confusion because they say, well, you know, the roots can still hurt. Well, we're talking about the core of the tooth being dead. The roots inside its jawbone are still viable. So if you pulled the tooth out with anesthesia, it's going to hurt like hell. That doesn't mean the tooth is alive. That just means it's a dead tooth that's still embedded in the jawbone. So once you have this X-ray picture of apical periodontitis, you have a dead tooth. You have a dead, chronically infected tooth. Typically, it evolves after deep tooth decay, blunt trauma, a slow degradation. I mean, hey, you get older, all your body parts start to wear out. So if you've been chewing on something for 60 years and it's done fine, and one day you chew a little bit harder and you get a linear crack, and it cracks all the way into the pulp. Once that pulp has been violated, that tooth is a gone pecan. A little southern expression. Now, they even did some interesting experiments to prove that this apical periodontitis was secondary to infection. They got these crazy experimental models with animals, and they've devised an experimental rat that's germ-free. So the oral cavity of the mouth of the rat is sterile. I don't know exactly how they do that, but they could do that. Well, when they take a germ-free rat and then violate the pulp, you don't get this picture. No infection evolves, no CAP involves. That's because you got to have infection. On the other hand, when they put a traditional microflora into the mouth, then this picture appears. So just a way to prove that this X-ray picture always means infection. Now this was, when I first saw this on my friend, I started asking the dentists that I know and work with and respect, I said, well, look, when you see a picture like this, they say, oh, well, that's going to hurt. I said, well, I don't think so. And then I say, well, let me put it this way. Maybe you're right, but this one doesn't hurt, and this one doesn't hurt, and this one didn't hurt. And then I examined the medical literature, and it's just stunning. But first of all, let me tell you about the 3D X-ray. The 3D X-ray is now fairly common technology. An implant doctor, almost all of them are going to have it. Most root canal doctors, endodontists are going to have it. And a few general dentists that are a little more prosperous are going to have it. So it's not most. I don't know what the situation would be like here. Not up on what the dentists do around here, but odds are if they do implants, they're going to have it here as well. Now the regular X-ray, the Panorex, is like a two-dimensional X-ray. The important point being here is when you have something two-dimensional and you cut an X-ray across it, you could have all sorts of pathology at different angles and you're not going to see it. On the other hand, the 3D X-ray is exactly what it sounds like. It's incredible technology if you've never seen it, but they do one quick rotation across the mouth and then all the information's in the computer. And I mean, just like science fiction, you can just manipulate it and look at all the different angles, and you can see what it looks like from above, from below, from one side, from the other. Point being is, you can have grossly infected teeth that the two-dimensional regular X-ray is going to miss 50% of the time. 50% of the time. Now that's not good odds to play with when you're talking about heart attacks and breast cancer and other forms of cancer, cerebrovascular disease, Parkinson's, Lou Gehrig's, Alzheimer's, all of these things. They actually did one study. This was especially elegant because they set it up so that they identified a certain number of teeth and they x-rayed them with regular x-ray and they x-rayed them with 3D x-ray, and they had the same radiologists and dentists read the same studies so they give it as much quality control as possible. Well, on that one, they saw these CAP lesions 70%, and on the 3D, they saw it 91%. Here's what CAP looks like. Oops. See the big space at the tip of the tooth? Okay. This is indicative of a root canal treated tooth, the filled lines. Now here's another one where you can see there's a big old cavity, infected the pulp, and now around both root tips you have these large radiolucencies. This was how big my friend's infected tooth was, and it felt fine. They looked at 103 patients who were undergoing coronary angiograms, and patients with CAP had a 2.8, a 280% greater chance of coronary heart disease than those that didn't have it. Now let's go on to the data on heart disease. I alluded to that a little bit earlier. Let me give you some of the, to me, that are stunning details, and you can appreciate that this is cause and effect and not just link or correlation. That's sort of the eternal comeback of mainstream dentistry or mainstream medicine when they don't want to acknowledge something that's overwhelmingly obvious. They say, okay, well, there's a link, there's an association, there's a correlation. but they won't say there's any cause and effect. And technically speaking, that can be legitimate, but they do it to the point where there's no common sense left. Okay? I mean, you can say that every time there's a crime, you eventually see a police officer, so the police officer is correlated to the crime, therefore the police officer did the crime. Well, obviously that's not the case, but that's how you make these bogus links. Just because two things coexist at the same time doesn't mean they cause each other. Well, I'm going to show you the data now indicates why all of the opposition to this has been such BS for so long. Now, even among the cardiologists and the internists, it's acknowledged and accepted that inflammation is the etiology or cause of all coronary artery disease. It's what causes the atherosclerosis to develop. But they don't answer the obvious question is what causes the inflammation? I can tell you right now that, and it's funny, but I don't mean it to be a joke, I mean it to be completely serious, is when a 55-year-old guy comes into the cardiologist or internist's office with chest pain and later develops a heart attack, and the guy says, well, doc, why did I get a heart attack? If the doc really said what he was thinking, he would say, or she would say, you're just unlucky. And that's what they think. They think if you get cancer, you're unlucky. Well, you are. You are unlucky if you get cancer, no doubt about it, but that doesn't mean that's why you got it, okay? Getting a disease of any kind, they all have a reason. Maybe you don't know what the reason is, but there's a reason. It just doesn't come out of thin air, and coronary arteries don't just spontaneously become inflamed. Now, I mentioned this earlier, Dr. Huggins' little quote. Now, for a very long time now, pathogens, along with their associated toxins, have been accepted as a major reason for chronic inflammation at all stages of atherosclerosis. And this is what is even more amazing because when you look at the lesions themselves, and look at this study, in the coronary artery plaque, they identified the DNA of oral pathogens typical for root canal and gum infections. Tons of studies. They've also done studies where they do a roto-rooter of the plaque. It's called a coronary atherectomy. They literally carve out the atherosclerotic plaque and then examine it. And they've consistently shown an incredible polypathogen presence of greater than 50 different species of bacteria in these plaques. Now, these studies are all in the cardiology and the medical literature, but it still hasn't occurred to any of these physicians that we always see oral pathogens inside coronary plaques. Maybe it has something to do with the mouth. Here is the gold platinum standard study that put the nail in the coffin. The interesting thing about this study, and I had a little email back and forth with the author because I wanted to learn a little bit more about what was going on. I have no idea why she and her co-authors decided to do this study because it was absolutely brilliant just to think of to do the study. They're at a medical institution in Finland, and they have a laboratory side and they have a clinical side. So it's an active hospital where they're treating patients, and it's also an active research laboratory. And she got the cardiologists who staffed the hospital to agree that every time a heart attack patient came in and the cardiologist would do the angiogram and see the blocked off blood vessel, that's what causes a heart attack, the blood vessel blocks off and then the heart muscle distal dies, they would aspirate, they would suction out that blood clot and then give that to them for analysis. About as elegant as you can get. Well, in 101 patients, they found DNA pathogens typical for endodontic root canal pathogens 80% of the time, periodontal 35% of the time. Basically, put those two figures together, and it's saying that greater than 90% of the time, you see in high concentration the pathogens typical for an infection in the tooth or the gums inside the blood clot that acutely blocks off the coronary artery. Now, to put even a greater layer on that, they found that the pathogen concentration inside this platelet blood clot was 16-fold, 1,600% more concentrated than in the blood. That, my friends, is cause and effect. You didn't suddenly have a sterile blood clot form and then this massive accumulation of pathogens and toxins took place. No, you've had plaques growing for years with documented pathogens inside the plaque, and now you get a massive release of pathogens from the root canals of the gums. They activate the platelets. You form a platelet blood clot, and you have your heart attack. So no link, no association, no correlation. This is cause and effect. This is clear-cut evidence that the root canal and the infected gums and the entities I'm going to talk about, like CAP, which have the same toxins and pathogens, but even more concentrated than the root canals, are why you get a heart attack. They're why you get breast cancer. They're why you get and aggravate every known chronic degenerative disease known to mankind. Okay? And you want to know something else? You know where this study was published? Circulation. Circulation, in case you don't know it, is the primary subspecialty journal of cardiologists. Question number one, do they read their own journals? Question number two, if they do read it, does it sink in? I used to be a lot nicer. I've gotten tired of being nice. Doctors in general, get far more respect than they deserve. The respect should be earned, not just granted. Now, they did some studies where they looked at the degree of atherosclerosis inside the aorta, just so they could monitor the effect of pathogens and toxins. They found that teeth with chronic apical periodontitis that were untreated, untreated means getting a root canal, that those were substantially more toxic than the teeth that did receive the root canal. So it was very clear just from this one study that if you did a root canal expertly, debulked the infection, and expertly sealed off the pulp so that it didn't continue to leak pathogens and toxins into the tips of the teeth, that this had substantially less negative impact on you than an untreated CAP tooth. So this means, quite simply, that the asymptomatic CAP tooth that I talked about when I first had my friend at the dentist is vastly more toxic than just about any root canal. And we already know how toxic root canals are. So we got to come around full circle to the point that in the world population, and I'll show you the statistics in a moment, this entity of an asymptomatic CAP tooth is incredibly common. Incredibly common. Probably when you combine CAP associated with a root canal and CAP on a tooth that never had a root canal, 80% or more of the adult population has at least one in their mouth. And many of them, quite a few more. And as you can imagine, all of this is cumulative and additive. I mean, if you have one pocket, that's 1 degree of toxicity. If you have 3 or 4 of them, it gets to be synergistic and not just additive. So just straight up CAP without root canals is probably present in 10% of the world population. But probably over 50% of the population now has one root canal, and many of them far more. And when you do the 3D examination so that you get better resolution, virtually all root canals have some CAP. It's a relative thing. A root canal can have a little bit of residual CAP, and if that CAP stays stable, doesn't grow, and is associated with a low C-reactive protein and normal metabolic syndrome blood work, glucose, cholesterol, triglycerides, etc., in my opinion, you probably have a tooth that you can coexist with for a long time without getting slammed by it physiologically and medically. On the other hand, if you have a root canal treated tooth with the CAP and your CRP is greater than 3, you better get it extracted before you get your root canal or your breast cancer, because it's really severely negatively impacting your general health, and you will pay the price. So I looked at, there must have been 15 or 20 different populations around the world. In this one particular study in Nigeria, and not all these patients are old. These patients here, you can see the patients are 18 to 60, not too ancient, at least not to me. Apical periodontitis was found in 75% of these people, at an average of nearly 3 affected teeth per person. 87% of patients at the ripe old ages of 40 to 49 had apical periodontitis. Okay, so people of all ages get cancer. People of all ages have dental pathology. Belgian study, not as dramatic as Nigeria, but still shows it's very common. And then, I'll spare you the mathematics and tell you that the current literature shows that somewhere between 7, which is still an astronomical percentage, and 20% of the adult population of the world have at least one tooth with CAP that has not been root canal treated. Basically, a silent, asymptomatic, infected tooth blowing your good health away. There's something else they call abutment teeth, where you have bridges and the tooth that they're anchored on. Here's CAP on an abutment tooth. This is interesting just because I stumbled across the article And they showed that 50% of abutment teeth that had a root canal had CAP, and 25% that had no root canal had CAP. But very interestingly, these were studies done with regular X-ray, which means if you did the 3D, ratchet it up. That meant that when properly studied, 40 to 50% of abutment teeth that did not have root canals had this pathology. And I mean, why is this significant? It's significant because if you don't specifically look at this, you're going to miss it. And I mean, the last thing you want to do is go ripping out permanent bridges and everything else, but something you want even less is to have that patient come back with a heart attack. So, Pesce's study showed that root canal-treated teeth and periodontal disease have a cause and effect relationship to heart attacks. And interestingly enough, they did a few other studies that showed that when these CAP lesions were present, the coronary disease evolved much more rapidly. And they also correlated, logically, that the larger the lesions were, the more quickly things evolved. So size of the lesion, all of this relates to how quickly and severely they impact the health. Now, this came out of the Journal of the American Dental Association in 2009. And it was just a statistical analysis, no more. But it was pretty impressive because the statistical analysis showed that individuals who had 2 or more root canal treated teeth were statistically more likely to have heart disease and heart attacks. Now, the one thing this study didn't do, and this is where it's a major defect in this study, is they didn't have any breakdown of the nature of the root canal treated teeth. Did they have a big CAP, practically no CAP? And this is the information that needs to be covered in future studies. Because as I mentioned earlier this morning, I mean, we definitely have 90-year-olds who are quite healthy that have had root canal teeth for a couple decades. And then we have 55-year-olds who get a root canal and they get a heart attack 6 months later. How do we figure out ahead of time what category you fall into? Now, Dr. Pesce and her group took their polymerase chain DNA testing to some other areas of the body. And guess what? They found that the same oral pathogens that they saw in the coronary arteries, they also saw in ruptured and unruptured intracranial aneurysms that would bleed and cause cerebrovascular accidents. So, not too hard to imagine, once those pathogens get in the left ventricle, 25% of them go into the coronary artery, and the rest go into the other blood vessels and straight up into the neck. Now, this next study they did, which extended this reasoning a little further, still amazes me because it would have never occurred to me to do this study in a month of Sundays, and I can't imagine what Dr. Pesce was thinking about, but obviously she was thinking correctly. They did this same analysis as they did on the coronary arteries and the cerebrovascular arteries. They did this same analysis on pericardial fluid specimens on autopsy patients that had coronary artery disease. And guess what? The pathogens were present there as well. And the worse the coronary artery disease was during life, the higher the concentration was seen in the pericardial fluid. Again, I don't know why it occurred to her to do that study, but it's pretty impressive information. Now, I mentioned earlier the important work of Dr. Issel's. He found root canal treated or infected teeth, multiple teeth, a full 98% of his advanced cancer patients. I mean, once you get above 90%, you're getting almost certain. Once you get above 95%, it's just mind-numbing to have something so strongly related to a condition like advanced cancer. But this is the role that chronically infected teeth not only play in chronic degenerative disease, but especially in cancer. Now, again, the title of the book references breast cancer, but don't let any cancer patient you're treating go without a dental evaluation. None, zero, nada. The other thing about the lymphatic flow back and forth with the teeth and the breasts is the lymphatics are generally designed to promote fluid flow in one direction. But after you get enough disease, enough pathogens, enough toxins, you get an enlargement of the lymphatics, you get a breakdown of this one-way flow, and for lack of a better expression, you get a back and forth sloshing of these pathogens and toxins between the teeth and the suffusing breast tissue. So, a regular Panorex X-ray misses a lot of pathology. It's the barest of screening tests, okay? I like to bring out the example of, has anyone ever diagnosed diabetes just by looking at the patient? No, you gotta have, number one, an index of suspicion, and number two, you have to check the blood level of the glucose. You don't say, wow, she looks like a 385 to me. You know, or maybe no more than 330. And that sounds silly, but it's not. I've told you, and we have the clear evidence that you could have the most grotesquely infected teeth on the planet, completely invisible to standard X-ray, and only visible when you do the 3D study. Here's the standard Panorex, okay? You know, a lot of teeth in it, not that much detail. Now here, we have this is a 3D study, just one shot. There's your root canal treated tooth. There's a huge radiolucency there. The sinus is half filled with fluid or pus. And you can see that the bony floor has been completely eroded away. Here's another tooth, not root canal treated, just received a crown. Again, same thing, total loss of the bony floor, problem in the sinuses, huge radiolucencies showing these teeth are chronically infected, and for the most part, completely invisible on regular X-ray. So here was that just little diagram just to show you the sharing of the lymphatic drainage between the jaw and the neck and the upper chest and the breasts. I mean, it's all one system. So, as we said before, you have two stages to any disease. You have resolve the disease as best you can and resolve the reasons the disease began in the first place and is continuing to be propagated. Two stages. So I'll reiterate, when you are treating any cancer, especially breast, the cause of the cancer must be eliminated along with the cancer itself. Lots of times you get these quote-unquote permanent results, even though you didn't address the mouth. But what else happened? Well, you gave the patient good quality nutrition, and hey, Maybe they got their thyroid treated by their other doctor and the thyroid function normalized. Let me tell you, you can have horribly infected teeth, horribly infected root canals, not impact you medically because the quality of your hormone supplementation, your thyroid supplementation, decreases the oxidative stress to the point that the infections won't seed. They won't disseminate, okay? And then furthermore, and they show different pathology in these CAP tooth. They like have 3 different pathologies. All 3 look the same on x-ray, same x-ray picture. But one pathology is a very pus-filled hole, just pus. Another one is cystic, walls it off. Another is granulomatous. But the point is our bodies are designed quite nicely when the right interventions are taken to wall off, not resolve, but to wall off infections to the point that you can physically coexist with them and not have them compromise your longevity. But you can't assume that's going to happen. I'm just saying it does happen, but don't be delusional and just say, oh, well, my body's going to wall it off, I'm going to be just fine. Now, we have the data that Dr. Pesce showed in the coronary arteries. I actually encouraged her to do the same thing for the breast, but she didn't want to do it. However, we have some other information that show that a periodontal pathogen known as Fusobacterium, very severe periodontal pathogen, in this one study, 2016, was found to be significantly enriched, this is their phraseology, significantly enriched in breast tissue from women with malignant disease. And interestingly enough, this same pathogen, now in this case, the pathogen gets down there by shared lymphatics. Well, guess what? It's also a pathogen that's strongly associated with colon cancer. Point being is, whether the pathogen disseminates into the blood, to the coronary arteries, whether it disseminates into the lymphatics, into the breast tissue, or whether it just gets into your saliva and you swallow it down into your gastrointestinal tract, all 3 places cause disease, and in the breast and the colon, it's malignant transformation. So, single most important cause of atherosclerosis and heart attacks, single most important cause of cancer of the head, neck, and chest, especially the breast. And remember that this is just getting worse rather than better, because depending on the statistics you want to look at, there's maybe 25 million root canal procedures done a year in the United States, not around the world. And they like to do everything the United States does, so y'all have just as many. Not a good thing, always following the United States. Especially with that iron fortification. Good grief. Make your food poor. Food pure. Yeah, don't make it poor. Now, it's not itemized here because there's too much detail, and that's why I wrote the book. You could get the detail from the book. But reviewed the literature extensively, and it was very clear that moderate to advanced periodontal or gum disease was associated, correlated with, it must have been 50 to 60 different medical conditions that I located in the literature, dozens of different cancers, all the arthritis, all the fibromyalgia, all the tumors of the head, all the Alzheimer's, Parkinson's, asthma, the list goes on and on and on. And in some of those cases, they made a strong case for it being cause and effect because they showed that a given disease, I think in one case asthma, when they did strong periodontal cleaning and helped resolve the disease, the asthma got better. And when the periodontal disease got worse, the asthma got worse again. Now that's getting pretty doggone close to cause and effect. Now the significance of all of these studies, because they didn't do these studies on CAP teeth, but we know from our knowledge of the pathophysiology of the CAP tooth is that it has these same pathogens and same toxins, only in higher concentration than in the root canal treated teeth or in the gums. So it's not a giant leap to say that every study that correlates moderate gum disease with these horrible afflictions throughout the body is all the more not linked but caused by chronically infected asymptomatic teeth. This is just a few of them, but like I said, there was like 50 or so. Now let me talk a little bit about the tonsils. Told you my own personal experience there. Let me say, I got to tell you something else too I didn't tell you this morning is, wow, that tonsillectomy was the worst experience of my life. It took, for me, it took a couple months before I could eat normally. And I don't know if you have this franchise here. Well, let's call it McDonald's. I mean, normally I'd fantasize about good-looking women and sex. All I could do is fantasize about cheeseburgers. So some people say they go through it well. Point is I would never recommend a tonsillectomy lightly. I mean, if you get a root canal taken out and your CRP comes down to normal and your other blood work improves, well, who cares what the tonsils look like? On the other hand, if you do that and the CRP doesn't change, then you got to start wondering whether that tonsil that was in line with the root canal is severely infected. Now, something that I've come across in the last 8 to 9 months that I knew nothing about 5 or 6 years ago is some of the new and extended applications of ozone. And we now have clear data showing that direct injection of ozone gas of the right concentration directly into the tonsils in many cases can cause a significant healing of the tonsils. It would be easy to track. That's where the CRP comes in so nice, as let's say, like I said, somebody still has a CRP of 4, and you took out their root canal, and it's still a 4. And you say, well, doggone, there's some other infection going on. Well, then, you'd inject the tonsils once every couple weeks for 4 or 5 times over the course of several months. And if that CRP comes down to 1.5 or 1, well, then you got a pretty good evidence that the tonsil was infected and that you significantly managed to largely resolve it, okay? The other thing is you need to look at the biochemical panel as it relates to metabolic syndrome blood work, which is glucose, cholesterol, LDL, HDL, and triglycerides. Now, the correlation needs to come between the dentists and the physicians. Now, when a cardiologist or an internist is treating a patient with coronary artery disease established, they need to go get a 3D exam of their mouth. If they have a positive stress test, they need to go get a 3D examination of their mouth. Truth be known, if they have any medical problem at all, they should go get the 3D exam of their mouth. It just gets to the point where you have to decide on economy. You know, if you're dealing with a poorer person, you know, the test is probably going to cost about $300. And probably with the nature of dental coverages, that'll be an out-of-pocket expense. Now, so that'll be massive for some people, not so massive for other people. But whenever possible, get a 3D exam, baseline. If you have a 25-year-old that comes in for a sports physical, I would encourage you to get a baseline 3D exam of the mouth, so when he develops problems when he's 31 years old or something happens, you can redo the exam, and if there's a pathology present that wasn't present at age 25, well, you're well on your way toward making the optimal intervention for that individual. Just like anything else. I mean, you get your fasting blood sugar checked for the first time when you're a young person. Same thing with this. Now, the dentist, when the dentist, in the course of doing his or her work, does a 3D examination and discovers this horrible chronic apical periodontitis, then conversely, whether they treat it effectively or not by extraction or root canal treatment, they need to refer the patient back to the cardiologist for a stress test. They need to see, has this chronically infected tooth already caused advanced but as yet asymptomatic coronary artery disease? So it works both ways. Now, basically there's four things you do, or you have an option of doing, when you find this CAP tooth on x-ray. Number one, you extract it and clean out the socket. Option number one. Option number two, do nothing. Not a good option, but nevertheless an option, because ultimately the patient makes the decision. You give them as much information as possible, but they decide whether or not they want to get a tooth extracted or whether or not they want to give you $500 to do it. Number three is, all right, I guess we have 5 possibilities. Number three is extraction, but extraction immediately followed by implant. Now, most people, as it turns out, will turn down an extraction and maybe opt for the root canal because they don't want to deal with a hole in their mouth. Not surprisingly. But if they have the option, assuming they can pay for it, to get an extraction and immediately follow with an implant, that helps them avoid slipping to the option of getting a root canal, which is still a better option than leaving the tooth alone. Okay. And when a root canal needs to be done, it needs to go to the highest volume endodontist in town. Everything has to do with repetition. And if you go to a general dentist that does 3 root canals a week, and you go to an endodontist that does 30 to 50 a week, you crunch the numbers. The canals always have anatomical variabilities. They don't fill up optimally the same way 2 ways twice. So experience is extremely important in giving the patient their optimal chance at getting a well-sealed root canal in which the CAP gets gradual and disappears over time rather than gets bigger. Okay? Also, as a practical point, because with the dentist and endodontist, you have a lot of ego involved. if a root canal was done by an experienced endodontist and is quote-unquote failing, and there's more and more CAP developing, you should never do a redo root canal. That's just BS. The anatomy is the same, and if this highly experienced endodontist couldn't get it right the first time, you shouldn't subject that patient's immune system to 6 months, 12 months, 2 years of unnecessary hammering while you finally come to the conclusion that this problematic tooth should just come out. Now, I mentioned the thyroid status thing earlier. And one thing I didn't mention is, you know, you deal with a lot of people, they all have their own opinion. Barnes noted that, and remember, there were only 4 heart attacks out of 1,600 patients over a 20-year period. He had a bunch of people drop out of the study because they just didn't want to deal with it anymore, and 30 heart attacks developed in that group. So the protection of properly adjusted thyroid is enormous. Okay, I talked about this and the ratio. So, root canal teeth are now established as a direct cause of acute MI. Periodontal or gum disease has long been established as a risk factor, and now with the sheer volume of studies we have on periodontal disease and different diseases, along with the fact that where they study what the disease does when you help resolve the periodontal disease, it appears fairly strong that the vast majority of those links or causes or associations are cause and effect. And number one thought is asymptomatic chronic apical periodontitis is perhaps, and I say very likely, the most undiagnosed and yet the most important direct cause of heart disease and other chronic degenerative diseases. So, to reiterate, you can't find it if you don't look for it. And this is what I said earlier, is it's really good if this 3D studies starts becoming part of any baseline history and physical, because even if you have a completely normal study at age 25, that's incredibly valuable information to have in the patient file when problems start developing down the road. Because the mouth and the teeth are very dynamic. They're not static. They're just changing all the time. As I mentioned earlier, we incredibly abuse our teeth. And at some point in time, they give in. And when they give in, they don't always give in a symptomatic fashion. You can crack a tooth and never know it and expose the pulp and have a big old CAP lesion that's been sitting in your mouth for 5 years. So not testing the patient, you're missing the single most substantial intervention in slowing, stopping, or even reversing a patient's heart disease, or in preventing and even reversing breast and other cancers. That about does it.